Hello, CAM followers. Please welcome the lovely Arianne and Kirsty, who are currently working for a dedicated osteoarthritis clinic called Nupsala Veterinary Clinic in Melton Mowbray. And Cam has invited them tonight to come and chat to you about what the future may be. In that, obviously, people that listen to Cam are very focused on arthritis, and we understand about the prevalence and we understand the enormity of this disease and how we can do so much more for it. But realistically, dedicated OA clinics are very, very in their infancy. So when I heard about these guys, I was like, right, we need to get them on and we need to chat about it. So in a minute, I'm going to let the lovely Kirsty and Arianne introduce themselves, tell us a bit about what they're up to. But first, I need to say, obviously, a massive thank you to our sponsor, Big Barker, who are definitely one of the most admirable pet, should we call it, accessory companies that I can ever imagine meeting. Having done a clinical study to back up whether they can market their bed as offering pain relieving benefits, improving mobility, improving quality of life. You know, most people use this terminology, free and easy, to market their product without any backing. Well, this company, and the reason that we associate ourselves with them, actually took it to a clinical trial at the University of Pennsylvania, and they did a pilot study to see whether they could actually state those facts, and they can. So we're really, really proud to be associated with Big Barker, and hats off to them for doing such a good job. Right, now back to these lovely ladies. Please introduce yourselves, give us a little bit of background, and then we'll crack on with the topic tonight, which is dedicated OA clinics. What are they? What are they capable of? And how can nurses take a greater role in OA management? So take it away.
Do you want to start? I'm Kirsty. I'm a registered veterinary nurse. I qualified in 2004, so I'm very old. I have spent most of my time in general practice. I have also done some teaching, so I have a certificate in education as well. So I've done some teaching of veterinary nurses, and I find myself here in Nupsala from February last year. Yeah, it's been nearly a year.
So. Yeah. Has it been nearly a year already?
Yeah, well, Arianne's like
Christmas. In December. Yeah. Yes.
Wow.
Yeah.
Okay, and
Arianne? So my name's Arianne. I'm also a registered veterinary nurse. I qualified in 2005, so even older than Kirsty. I've done all sorts. I've been in referral. I've been in general practice, first opinion, and I've also done charity work, both here and abroad. And yes, I've been here since December.
And I think this is a really good opportunity to just big up what registered vet nurse means. So please explain to people what that actual terminology means and why it's so important when we talk about an RVN, for example. But then I just think it's great to give nurses a little bit of a big up of how exciting this career can be. So tell us what registered vet nurse means to start with.
So, well, it means we're accountable for our actions. We still work under the supervision of a vet, so we are still under their, can't do anything kind of without their say-so. But if you Google us on the RCVS, you will find our names on a register and where we are in the country, and we have our own individual numbers. And we're accountable for our actions. We have to follow a code of conduct. There are 5 principles we have to follow. So there's honesty and integrity and all of those kind of things, really. And so, we work very hard. And in my opinion, the title needs to be protected, but that's a whole But yeah, so.
Yeah, I think a lot of people really underutilize nurses. When you consider the training that you guys go through, and the knowledge that you have, and the CPD that you do, and all the additionals that you do to get to where you are, And I sometimes find it frustrating that the public don't realise it's a service that they can tap into. So that's something we're going to talk about after we talk about dedicated OA clinics.
Mm-hmm.
But I think it's really fair to just really, as I say, big up nurses in that by being responsible for their own actions. That actually hasn't been around for very long. Is it 10 years or so?
Yeah, it's not been very long at all. I think I qualified in 2004, and we were the first cohort to automatically go on the register. So up until then, it was a choice. And I think then the charter came in, didn't it? And then that was kind of another add-on to that.
Yeah.
So it's not been very long at all. But
No.
but the vets couldn't do the job they do without us. So
No.
it's, it's
100% agree. We've got a new vet at the practice I'm working at. He's lovely. He's called Callum. He's absolutely divine. And I was telling him about how on call, a lot of people fear on call now. A lot of people want that 9 to 5 lifestyle. But actually, when you're a new vet, doing on call can be a brilliant opportunity. And I was talking to him about the person that taught me to do a thoracocentesis, which is putting a needle into the chest and draining either air, some form of fluid off, was a nurse. It was a registered vet nurse, and I will always be grateful to her. So nurses take quite a big role in looking after the new graduates and, sharing skills. So a really high five to you guys, what you do. But as I say, we'll talk about what registered vet nurses can bring to an OA management plan in the latter part of this live. First of all, we're going to talk about this concept of a dedicated OA clinic. Now, you don't need to sell it to me because you know that I'm 100% there. It's like, yes!
Oh.
But what does it mean so people have an idea what we're talking about?
To me, I think it's the time we have, because we're only focused on the osteoarthritis, and our consults tend to be at least an hour.
Yeah.
So that's, you can't, no matter how good your first opinion practice is, they simply haven't got that amount of time to spend on coming up with a plan, doing the whole physical exam, making the decision of, okay, what in your case is going to be the best way forward. And they or most times won't have the equipment that we have available to us either. So yes, a trot up in a car park isn't quite the same as what we can do on the treadmill behind us here. It measures every single step that an animal takes, whether it be a small dog or a cat or, a very big dog. Every single step it measures, whether it be the pressure that goes through each single toe, the step length, the symmetry of the gait. And yeah, that's simply not feasible in first opinion, unfortunately. Okay. So that's where we can kind of, be that addition and extra to a first opinion practice.
Yeah. And I think I want to just put it into a little bit of context so owners and other professionals that are listening. When you look at what we give the average OA patient, osteoarthritic patient, compared to a dog that's, say, being diagnosed with lymphoma, which is a form of cancer of the lymphatic system, it's just non-comparable, because when you have a dog that has maybe presented with a cancer that's a systemic cancer, they come in, they get clinically diagnosed, they have bloods, they have urine samples, they have diagnostic imaging, all this data is collected, they take biopsies of the mass, they take biopsies of the lymph nodes that drain the mass, they bring all this information together, they give you a grade, a stage, they give you a bigger picture of where you're at with this disease process. Most osteoarthritic cases are spot diagnosed due to the owner's observations, or the dog's just slowing down, just getting a bit stiff, and then immediately goes down an avenue for life of, we assume it's osteoarthritis. And when you think that osteoarthritis is now considered a welfare concern, and it's a leading cause of elective euthanasia, it's really a bit weird, when you kind of look at the facts and the figures that are for these systemic cancers, heart failures, all of these things, and the lengths that we go to when we've got something that's more prevalent that doesn't get the same attention. So I just wanted to put that into context for you guys, that dedicated OA clinic that's going to really, accurately diagnose, grade, stage, come up with a multimodal management plan, bringing in all available options, kind of makes a lot of sense when you compare it to the way that we manage other diseases. Do you agree?
Yeah, I do. I think it's a disease that, or a syndrome up until now, has been, as you say, it's just associated with the elderly. But actually, it's not just that, is it? It's the younger ones that are getting it, whether that's a conformational thing or a breed thing. And we are also here for them as well. So we are very much, and our vet especially is very much into sort of the preventative side of things. So it's getting that baseline on it, it's a younger dog, and then tracking that to try and pick up early and intervene early before we get to the point where it's a welfare concern, and then you're kind of staging a management plan as opposed to trying to intervene and slow down the progression of the disease. That's where we want to try and get to. I think that's the ultimate goal.
Yeah. And I think within the working dog community, we are starting very baby steps on that path, so that we will be tracking dogs that are at this point still healthy.
Yeah.
So we get a baseline of, okay, their gait was this, and then you can, if that changes at all during the course of the next couple of years, we can intervene before it becomes debilitating. And that's sort of something, I mean, it's a complete shift of thinking to, okay, we need to catch it before it's a problem rather than firefighting at the end.
Yeah. And that's the beauty of the treadmill as well. We can repeatable. So the baseline, we know what speed we ran the dogs at, we know, so we can go back and do it again at the same time. So the results will be comparable. So we can see the differences as we go through. And that's the beauty of the treadmill, which the trot up in the car park isn't necessarily going to tell you.
We shouldn't diss trot ups in the car park, though.
No, we do that as well.
Not.
We do that as well.
Yeah.
We have that too. We do have it, but just from a picking up the disease protection as well. It's part of the bigger picture. We use all of them. We've got as well that they just stand on and it's static and looks at the.
Yeah, I guess what I'm trying to push really quite heavily in this first part of the interview is this is not superfluous. This isn't only a luxury. This isn't for those that are really super paranoid owners. This is not. When I consider myself quite a normal dog owner. I have normal expectations, a normal lifestyle with my dog, who I just want her to live for as long as possible, as comfortably as possible. But having been through it with my last dog and realizing, how much it destroyed our lives for a long period of time, how it led to our world getting narrower, all the things that we enjoyed doing together being taken away, and I basically became her carer for the last couple of years. And this is not uncommon. This is really, really common. So because of that experience, I now do watch Luna's weight, especially conformation. I look at her posture. I look at the way that she's laying. I look at the way that she's walking. I look at her coat. I look at her nails. And I'm permanently going, are there any signs that something's happening? I do exercises that strengthen her core, because my last dog got lumbosacral disease, and I'm always flexing and extending her joints. We'll go out for a walk. The locals think I'm mental. They'll just see me 6:30 in the morning with my coffee, doing a quick orthopedic exam with my dog, going, has anything changed? But I just think that once you realise that it's the leading cause of elective euthanasia, you'll do anything to make sure your dog doesn't get you flee, you worm, you vaccinate. Why wouldn't you be doing this? It makes obvious sense to me.
And our dogs are living longer as well, aren't they? And I suppose that's the other thing, you know, that our dogs are living longer. So, you know, the idea of them getting sort of arthritis later on in life as well is something to be aware of. So we can, like you say, you can intervene before you get there and think about weight loss or weight management and physio and exercises and different behavioural enrichment and that kind of thing. So you can support them.
I want more information going out in puppy packs. I want people to be taught what appropriate exercise is, what, you know, an appropriate growth curve is.
Yeah.
You know, advice about leads, harnessing. Just so like, ah! Okay, so let's get back to this dedicated clinic. Tell us what's kind of like the features within a dedicated clinic. So we've heard that you've got more time.
Yeah.
And the focus is on osteoarthritis and therefore the consequences of it, you know, the compensatory changes, etc., etc. We've got 2 nurses that are dedicated and trained in that area. We've got a vet that's very focused in that area. But what other facilities are within your practice alongside this gait analysis that is really showing that it's targeted to musculoskeletal disease?
Yeah, so we've got the treadmill, which you can probably see behind us.
Yeah.
As I say, we've got a stance plate that the dog stands on, and again, that gives us how much sort of pressure they put through each foot. We have a digital radio.
Explain why. Okay, let's do that. Let's do one by one. You know, so we've talked about gait, talking about pressure and gait, stride length, peak vertical force. Tell us about a stance analyzer. What do you mean? Because people are going to go, yeah, what?
It looks like a set of scales, basically, without the weighing part. Or it does weigh as well, actually, doesn't it?
As well.
They have to put a foot in a quadrant, so it's split into 4. So if you can imagine a mat that is split into 4, and then they have to put 1 paw in each, and then the computer gives us a reading of how much pressure they're putting through which foot, and it gives you a percentage, so it adds up to 100%, and that just tells us if they are, so say if they're sore in one foot, they might not put as much pressure through that foot, so they'll offload and put more pressure through the other foot and so it gives us an idea of kind of where we're at. But that is actually, for us, it's the hardest piece of equipment to use, because dogs are taught to sit. They're not very often taught to stand.
Yeah.
And then they don't like it very much. So there's a lot of bribery that goes on with treats and pulls and kongs, because
it's actually, as you say, it's very, very hard for a lot of, you know, average dogs, you know, normal owned dogs to stand square.
It's really tricky.
Yes.
It's really, really tricky.
It's something you'll probably see in show dogs, but not a lot of other dogs.
No. And what they tend to do, so for the people that are immediately going, oh my God, that's so inaccurate, that's going to give you just a one-off transient picture in time. Well, what you do is you've got a little handheld clicker and you're there very much trying to hold the dog in as neutral position as possible. And you're clicking, and you're capturing loads of these, you know, average weight bearing. And then the amazing technology of the computer system will, you know, filter it down and give you a mean average. You obviously can get rid of the outliers if they're really absurd. You just can get rid of them. I think the program now does it automatically, doesn't it?
Yeah. So it one click gives you 25 readings, and then you can filter those out. The ones that are completely out of normal, it filters out automatically, but you can still take individual readings out. So we try to take on average about 3 sets of readings, and then filter down. But it'll give us an idea of where they're at now, and you know, we can repeat that, and if we've done an intervention, we can say, okay, so the weight has, from offloading on that foot to so big a percentage, it has now improved to only being like a lower percentage of offloading. So it's very much, all of these things are very much looking for the trend within the animal rather than pinpointing
Yeah.
Yeah.
And that follows in, Alicia, what we will do is we'll kind of answer your question as we go along, because you'll start realizing there's lots and lots of different facets to diagnosing osteoarthritis. It culminates in X-ray or CT or MRI, but actually you can get a hell of a lot of information first. Stance analyses are great when you get the classics, the unilimb lameness, which we all know is actually not that common. So that's why they should never be used as a diagnostic tool, but they're very good for monitoring, and that's what we're trying to do. Is we're seeing improvement. Okay, they're a pretty expensive piece of kit, aren't they? They're I can't remember how much they are at the moment, but they were
because it was here before
Yeah.
either of us started.
Yeah.
So it was
many thousands of pounds, shall we say? Many thousands of pounds, and like the gate and analyzer, many thousands of pounds.
Yeah.
Okay, what else do you have? Or do?
What else we do? So we also have digital X-ray, so that we do have that as well, and we do use it. So that we have that. We also use a software. Am I allowed to name names, Hannah, or not?
Yeah.
So we also use an online questionnaire from it's called AIMOA, and the owner completes that ideally before they get to us, so that we've got an idea already of lifestyle changes, lifestyle choices, whether they've got laminate flooring or rugs or carpets, exercise changes, behavioural changes, what leg they think that it's lame on, or legs plural. So we get an idea as well before they come in, and then we've got the vet completes the other part of it. So then we get another kind of picture, and it helps with the clinical history as well. So we've got an idea of
I think that's a really good point, because one of the things that we teach is trying to get owners to be concise and targeted with the information. And these questioners are very good at this. So quite often, please take this lightheartedly, you kind of like pick up the phone and the owner will go, so last Saturday we were off the way to the co-op, and when we were there, like a bird flew past and the dog did, and you're like, just tell me what is going on. So one of these tools is really good, is actually trying to get people to drag out the relevant data in a concise manner, because I think what owners have got to remember is the vet's brain and the vet nurses are going, is that important? Is that important? Is that important? Whilst you're talking at them, and they're grabbing pieces of information and trying to assimilate and create this amazing algorithm of what we think is best or what we think is happening. So when people take you on the most fantastical journey of what happened last weekend, you're like going, very relevant content. So yeah, these questionnaires are great for that, aren't they?
Yeah. We've also got like a questionnaire that we've made up ourselves, that we send out to new clients, and it's a lot to do with lifestyle and as Kirsty said, what sort of flooring have you got? Have you got other pets? You know, what sort of behaviour has changed? Are they still sleeping through the night? But part of it as well is simply the question, what do you hope to get out of coming to us? Because if we can see, okay, that might be a manageable target, then you know we can work with the client, but it also gets the client thinking about, okay, what is it that I specifically want? Because you know, do we just want them to be able to have a pain-free life, better quality of life, or do we want to go back to, you know, an hour-long walk? And how do we then manage those expectations of a client, which, you know, having seen that questionnaire will give us an idea of where we are and where we want to get to.
I think that's really hugely important, and I think I'm pretty safe to say the biggest area of complaint, litigation in any of the medical sectors is miscommunication.
Yeah.
There are very few bad people, be them owners, be them vets, be them vet nurses. It's actually just cross wires.
Yeah.
And by having somebody say, so where do you want to be? Are we talking about a dog that's going to potter around, the village? Or are we going back to high-end agility? Is really, really important. Totally agree.
Yeah.
So do you ultrasound?
We don't have ultrasound, no.
No, but that's something that's
it is on
yeah.
the wish list, but yeah, we're not there yet.
Yeah, I want that on my
wish list. Yes.
real wish list is ultrasound, MSK ultrasound. I want to be Gigliola Spatini. She's amazing.
Send her our way.
I know. Wow. So other things that you'll find in a dedicated OA clinic is also the confidence to start sampling the joints. And I think that's something that we small animal practitioners, our dog and cat practitioners, we're less confident to be tapping into joints. And that's what we call it. Joint taps.
Yeah.
And I would imagine in your clinic, you're much more confident and comfortable doing joint taps, taking fluid, analysing. And this fits in with Alicia's comment of, is X-ray the only way to diagnose OA? It's not at all. X-rays show end stage changes. Actually trying to get details of what's going on earlier is by sampling the joints, clinical signs, behavioural changes, palpation, but also sampling joints. So do you find yourselves doing that quite a lot as well?
We have done that. We have tapped joints and taken readings off of joint fluids, so specific gravity mainly.
Yeah.
And then we offer our sort of regenerative medicine as well. So we offer things like hydrogels and PRP and stem cells, although we haven't done any stem cells yet, but we've done lots of hydrogel and PRP.
Yeah, absolutely. Yeah. So basically the dedicated clinic, when you're looking at the utilities, we've got things that are much more focused about collecting data about musculoskeletal change. And it's not things that you'd find in normal practice. You'd find the weighing scales, but you wouldn't find a stance analyzer. You would see a vet hopefully doing a gait analysis in the car park or in a long corridor, but you wouldn't see a treadmill that can actually calibrate force, distance, placement, etc. X-ray facilities are getting better and better across the board, but it's really ramped up in the last 5 to 10 years. And some of the quality X-rays you can get digital are just insane.
They're amazing.
They look like CTs, don't they? They're just incredible detail. So also that would be something that you'd have a higher spectra. You'd have more competencies of people with regards to being able to palpate, examine, methodically work out what is going on within the body, and also the confidence and the competence to go and actually start sampling from the joints to get a more greater understanding. But what about the actual clinic lifestyle wise? Because I know who built it and I know that a lot of thought went into the design. And what sort of things have you guys thought of to make sure it caters for the OA cases?
So basically from the door starting, at the front door, we make sure that there's what we've got is yoga mats, so that they don't slide all over the place. With regards to coming into the consult room, we make sure that they're comfortable before we actually do anything with the patient themselves. So 9 times out of 10, we let them off the lead. They can have a mooch around. They can lie down on a soft mat if they prefer that, or a bed. They can take their time just getting to grips with the environment and us, whilst the owner talks to the vet about, okay, this is where we're at, this is what we're doing, filling in the AMOA bit. and then very gently we coax them onto the treadmill, basically whilst the owner's kind of still talking to the vet. So there's not that, oh my God, will he do it? Will he not do it? It's all very much taken at the dog's pace. And unfortunately, some dogs really don't like the treadmill the first time around. There's no point in trying to force them, you know, we just take our time. And sometimes that means that they might have to go on their treadmill the next time they come to see whether they'll accept it then. Same goes for the stance analyzer, you know, the amount of treats that we dish out, but there's, you know, you need them as relaxed as possible to accept the physical examination as well, because, you know, if it's likely to be painful, you don't want an animal already stressed about being here. So we really just let the dog decide, or the cat or whatever, you know, decide on the pace that we go at. And so
which is something that you're not going to get at first opinion practices.
No.
There's too much going on, and it's certainly not a diss, it's just a different requirement. There's animals going into first opinion practice that might have dental disease, heart failure, lump, they might be itching, they might have ear disease. You don't know. And there's going to be quite a high turnover. There's going to be quite a few people in the waiting room. There's going to be 3 or 4 consult rooms with doors opening and vets asking people in. At any one moment, you know, the car park will be full, the phones will be ringing, the nurses will be coming and collecting patients for operations. So it's kind of like a crazy, like almost a Where's Wally kind of experience in the first opinion. But what you're describing is much more a targeted approach. You're the owner and you're the only one in at that time, and I'm going to give you a lot of space because we want that dog to perform as they would do at home. So sit how you'd sit at home, lay how you'd lay at home, walk how you'd walk at home. So I know you've got a lot of space. I know it's very quiet. I know that there's a lot of stuff in and around to make it feel quite natural, isn't it? You know, the wall art is very calming.
We've
It also makes the owners calm.
We've got plants in the waiting room as well, and there's a coffee machine because people have been coming from quite a long way away as well. So to make sure there's, you know, coffee and there's a toilet they can use, and we've got non-slip vet bed as well, so the dogs aren't sliding all over the place. And
and I think this is cool because a lot of nurses that maybe listen to this and they're going, oh, what can I do? You know, my clinic, I've got a first opinion kind of craziness, but you can still do the yoga mats and, you know, the vet beds, and you can have the raised water bowl. You can lead by example. You know, you can have maybe a quiet area to the waiting room. But Sarah Heath will love all this. I love Sarah Heath. She is an absolute heroine of mine. But the idea that we're trying to allow the dog to be as natural as they can be, so we can get the most information out of that. Now, you've also got a gigantic consult room.
We're sat
why is that important?
Space, basically. Once the stance plate is on the floor, and we've got a mat, dog bed mat thing as well, and that's quite big as well once that's on the floor. And it's just because there's normally 3 of us in the room plus the owner, and so you've got 3 members of staff as well with you most of the time. So again, it's that ratio, patient to staff ratio, which you wouldn't necessarily get in a general practice either. So it's, again, I guess that's a novel thing. So that's why we've got the big console room, because it's just space, and the dog can go off lead, like Arianne says, and they can mooch about, and they get on the treadmill of their own accord sometimes, especially if they've come back for a recheck. They're straight on it going, come on, where's my treats? Where's my licky mat? I had that before. Where aren't you got that out already? So it just gives them that relaxing, positive experience. And if it's a positive experience, they'll be all right to come back.
And they're going to behave more naturally. And what we're trying to do is collect information about their normal movements, their normal behaviours, so that we can make a decision of you know, what's the best intervention, and then is the intervention that we chose the right one when they come back for these reassessments. Okay, so you kind of started to kind of allude to what is done treatment wise within a dedicated OA clinic, but just kind of like run through the sort of things that your clients are routinely going home with, from very conservative, what you'd find in first opinion practice, all the way up to, as you started saying, things like intra-articular. What kind of stuff do you do there?
So I mean, it, like you say, it ranges. We send some back to their general practices with non-steroidal anti-inflammatories sometimes, or purely for further. We haven't got a CT here, so if we think it warrants it, they go back and have a CT. You know, they're sent back with referral notes and that kind of thing. What else?
Wow.
You would offer, you'd like, so okay, let's put it into context. So you've got an owner that's chosen to come and see you. They've only had a brief chat with their first opinion vet, and the first opinion vet, you know, admires their dedication and is quite happy to refer that owner with very little workup done by the first opinion practitioner straight onto you. You'll be able to cater for them all the way through to the ones where the first opinion vet's really struggling to manage the cases. Is that kind of what you're trying to say? And you then open up a portfolio of other interventions that might be something that they couldn't access at their first opinion vet.
Or they self-refer. We take self-referrals as well. So we have, more often than not, we have owners saying, we need some, it's not working. We know it's on a type, you know, it's on all of the medications it can possibly be on, and he's still lame, and we want a better quality of life, and we want something else. And what can you do for us? How can you help us? We have that's what we have as well. So we don't necessarily need to have a vet referral. They can self-refer.
They can self-refer, but then the vet has to agree to.
Yeah, so then we contact the general practice and say, look, this has happened. We request history. We keep them in the loop. We're not here to, we're here to be a complementary to the general practice. We're not here we're not instead of, whereas as well as. So it's not that, because we just do OA. There is no general practice provision here. We don't have a facility for anything else. So we're as well as, we're not instead of.
Yeah, and I think a lot of people will be like, "Oh, I can't get my head around that." But having seen it in action in other places, say you came with your dog and the lead vet of the OA clinic was concerned that there was a comorbidity. For instance, there were coat changes, increased thirst, and the vet was thinking, I think we've got Cushing's here. Yeah. Then at that point, he'd have a discussion with the chief vet, the first opinion vet, and say, I would like to send this case back to you. We need to get this investigated. I'm not going to step on your toes. This is your sector. This is your baby. But when you feel appropriate, I'm really, really happy to see that client again.
Definitely.
Yeah. Okay, cool. So that kind of like leads us into our second half, in that, yes, these practices quite often will have, and I'm not sure if you guys do, but a lot of these dedicated OA clinics, which are becoming more common in America, will offer interventions such as laser, which is becoming more commonplace, extracorporeal shockwave therapy, other complementary kind of like alternative therapies, be it pulse electromagnetic field, targeted pulse electromagnetic field, shortwave. There's just so many other things, but also intra-articular. Mm-hmm. And this is something that is common in the equine sector, but it's really not that common in the small animal sector because of university training. It's not commonplace in university training. So there's a hesitancy about doing anything with the joint. But these clinics or these disciplines within your clinic are now beginning to focus about what we can put into the joints. And that can be from very primitive in the form of, say, a steroid, all the way through to a polyacromide gel, which is like a viscoelastic polymer type gel. There are different things that we can now put into joints. And a perfect situation for that would be is a dog with a very obvious joint affected or a couple of joints affected, and actually getting the pain and the dysfunction under control there, we're going to get the dog to start weight bearing and using the full range of motion, and everything's going to go back to balance, and we're going to have this really nice, comfortably weight bearing in all four limbs and an appropriate posture dog who's got amazing energy and capability. And how amazing would that be? So intra-articular is a really, really developing field, and this is where you guys are really, really excelling. Let's kind of push on and start patting the backs of vet nurses. What do you do within that clinic so that people can learn what nurses are capable of, and that is accessible to them in their first opinion practice? Because let me just put some context to this. We were very lucky in 2019, Hills Pet Foods invited Cam to do a tour around the UK teaching nurses, and we did 6 different dates in all the parts of the country, and we got to lecture to a room full of nurses. You know, there could be 60 to 100 nurses in a room at each of these events, and the common questions at the end were, I'm really excited and I really want to do this, but my practice don't see the need. They don't have the requirement. They're not being asked for it. So what did Cam think? We think, well, if we teach the public of what you guys can do, then they will go to the practice and say, I'd like to see a nurse. And then the nurses are like, oh, thanks, I need it. Oh, I want to set my clinic. And then everybody's happy. So what do nurses do?
Main thing, I think, is listen. Just simply listening to the client and having that maybe little bit more time to spend with a client. If you, for instance, got a laser within the clinic, you know, you're in that room with the client, with the animal. The client is more inclined to chat about, you know, how things have been going, how there's progressing or not progressing, you know, the worries that they have. There's maybe a little bit more of a barrier towards a vet, and it's a shorter, you know, they feel they've only got like that 10 minutes maximum, and they need to, you know, the dog has got an ear problem, it's got this, it's got that, it all needs addressing within that 10 minutes. Whereas if you're seeing a nurse, it's kind of a bit more informal possibly, and therefore
well, it's actually proven. So this isn't anecdotal. There's been studies to show that nurses are more receptive to the signs of pain. They're more likely to pick up on subtle indications of pain, either in the owner's history and observations, because nurses listen more. There was a study where I think they looked and found that vets like me, just butt in, like I've just done, we're very quick to talk over owners. We're very quick to get control of the consultation, and therefore we direct it how we want it to go. Whereas nurses are better at listening, and the consultation will go where the owner wants it to go a little bit more, which can then bring out more information. So you guys pick up more than we do, and that's proven.
Yeah, I think nurses are ideally placed to be that bridge between the owner and the vet, and, you know, kind of bring it all together and maybe think outside the box a little bit. Like, you know, have you thought about maybe getting physio, or, you know, and there's a good physio around the corner. Have you tried, and that sort of thing. And there are other options rather than, oh, you know, it's not a candidate for surgery, therefore it's on the NSAIDs already, and that's kind of like, there's no, you know, there are other options.
There's also the education point of it as well for nurses. We have that, you know, especially if you're newly qualified as a nurse, or you've done some CPD recently, or you watch CAM, which we do a lot, you know, you can go in and talk about things like scent work rather than long walks, and snuff format. So rather than going, actually doesn't need an hour walk, if, you know, you can do some scent work, which is short bursts, or you can use environmental enrichment, or you can get rid of the food bowl completely and and make them work for it. And so I think it's also, we are better placed to give the education. The licky mats we use in clinic, and I know Cam have got them as well. So again, it's things like that. And we had a client in, well, I've never seen this before. What is this? And it's like, and the dog was absolutely, well, we had to take it off the dog because they got really enthusiastic, but they were like, what is this? I've never seen this before. And we were like, well, so I think it's that as well.
Yeah, and I think you guys are able to discuss nutrition. You're able to discuss weight, and you're able to structure a weight loss plan, which I'm hugely passionate about at the moment. I think people think once you're 20, I'm 20 years a vet now. And somebody asked me the other day, what do you enjoy doing the most? I'm like, oh, my weight clinics. They're like, what? Surely you should be doing like lobectomies and surgery by now. Right? No, I love my weight clinics. Because it's just the best thing when the weight's dropping off. The owners are happy, the dog's happy. And what I've realized is that you can't say to an owner, your dog needs to lose weight. You have to say, your dog needs to lose weight, and I'm going to help you get there. And this is what we're going to do. And this is what we're going to feed. And this is how often we're going to feed it. And this is when I'm going to see you again. And this is what we're going to hope to lose. And this is how long it's going to take. And owners really like a plan, and nurses can create these plans. As I said, you can give advice about the environment and their adaptations. Does anybody ever bring you in videos of their home? Have you had that yet?
No, not yet. Lots of videos of them out, like walking and running and that kind of thing, but nothing at home yet.
No, that's another thing that we're thinking of doing it in Cam. Actually, we want to create more and more services via the online, but we don't want to stand on anybody's toes. We always want to be seen as a support. We don't know of anybody that is analysing footage of home environment, and we're like, could we do that? Could we be able to take like a video clip around the house and go, what should we change? And I'm like, why not? So there's lots of things. So that's cool. Exercise advice. Many nurses are beginning to get training in rehab and physio. Some nurses are also qualified physiotherapists. Either of you two do any physio?
No, but then we've got a brilliant physio literally on the same estate, so it kind of seems a bit silly to, kind of double up there.
And lots of our clients actually see her, so we share clients. So it's and we've been round and she's brilliant, and so we've got a good relationship with them.
Well, there's definitely, I'm noticing a huge surge in veterinary nurses and vets that are taking a more rehabilitative approach to their ongoing learning. So you might find at your first opinion practice, the nurse clinic will also offer you an exercise program. They might give you basic massage tips. They might be able to do manual therapies and use these complementary utilities like laser and stuff as well. So the nurses can do a huge amount, but they tend to be great listeners. And I think we forget how powerful that is, in that when you look at the chronic pain sector for humans, a resounding requirement is time and willingness to listen, so that there's empathy, understanding. A management plan can be created that's suitable for the owner rather than being told. That's a common problem. If you get told what to do and no one listens to what you can do, then that management plan's likely not to happen. So I think nurses just are untapped, and they really need to be utilised more. Can you add to that?
I agree. No, I don't think so. I think
in a way, maybe, like, at the end of the day, we're providing a service that the owner needs to be able to afford. So, that conversation needs to happen as well. Not only do we want what's best for the animal, but we can't forget about, what is best for the owner.
Yes.
And that needs to be like a something that is balanced. And, you know, maybe it is just an extra medication, or, you know, let's start with this and see what improvement that brings, and then potentially, you know, get more on board. But yeah, that's, to me, that's very important, is to, you know, consider what is possible for an owner, and, you know, what there's no point in starting on a long, you know, plan if halfway through they have to like stop or
I think both vets and nurses should be empowered to do that now. I think all of us should learn the vocabulary and the tone and the timings and the comfortableness of saying, this is what I'd like to do, but I really need to talk you through this because I want to make sure it's something that's suitable for you, be it physically, emotionally, and financially. We need to make sure that we've both got the same vision. And my vision is broad. So I can be at this end of the spectrum or that end of the spectrum. I can work with you, but we've got to talk about this. And I don't think we should be uncomfortable having those conversations. But I do think nurses have less white coat effect. So the conversation is easier. It can be brought up quicker, in my opinion, anyway. Cool. Well, so we've done quite well. I think the nurses around the UK will be pretty proud that you've fought their corner. Good. And Alicia, so these lovely ladies, there isn't a specialism for osteoarthritis with nurses currently, but saying that, a year ago we started talking to the BVNA about potentially creating an OA specific qualification, and one day we will do that. Because
VOA.
Yeah, there is the VOA Blue Cross award, which we both have.
Yep. So that's the Veterinary Osteoarthritis Alliance. There's a further accreditation, so understanding much more about the syndrome OA. There is nurses out there that will have done, as I said before, rehabilitation or physio. They might have done more qualifications in nutrition. They might become a surgical nurse, so they're very good with the orthopedic and soft tissue surgeries, or they might be a more medical nurse and dealing much more with inpatients and medical management. So there are specialisms within nurses, but for the OA situation as such at the moment, it's just passion. It's about nurses that find the area really, really interesting and can see that so much more can be done. Right, let's do our 10 top tips. Luna's getting a little bit antsy-pantsy. Luna is here. Come on, Luna, stop up. Are you going to come? There you go. Me and Luna are supposed to be on holiday, guys. So we're on my camper van again. It's so common that I end up doing these Facebook Lives whilst on holiday in a camper van.
Feeling guilty now.
No, don't feel guilty. Don't feel guilty. Right, let's start off with 10 top tips. I'm going to start with 10, which means that you're going to end up with number 1.
Okay.
And there is slight pressure that number 1 is supposed to be kind of like, oh, wow. But so number 10 for me, I'm going to steal it.
Go on.
Please use your veterinary nurses. They are available. They are highly qualified. They are not simply cleaners in uniforms. They know stuff. Please utilize them. Number 9.
Weight. I think weight management. We are still seeing a lot of our patients are on plans or need to be on plans, or and I think more than that, I think more about the fact that they need a bit more enrichment. So I'm very much get rid of the food bowl and do something with it, rather than there's no rules to say you have to put it in a food bowl.
No. And there's a brilliant book called Beyond the Bowl by Diane, and I can't say her surname, but if you're thinking, oh my god, I need some imagination, Beyond the Bowl. Number 8 for me, you already talked about it, flooring. It's mine. I love it. More rugs, less drugs. it was one of the really big drivers of us starting CAM, was the amount of people that didn't realize just how much of a difference it can make. Number 7.
Anything you're worried about, like be it behavioural changes, posture changes, you know, if something doesn't quite feel like it has been and it's not, you know, just a one-off, get it looked at. And if the vet doesn't see it the first time, get it looked at again. Don't give up. Just if it's not right and you know it's not right, then persevere.
Trust your instincts.
Yeah.
Sure.
Number 6 for me, we're definitely seeing a huge change in this sector. It's really exciting. 10 years ago, sorry, Lena, 10 years ago, I started getting interested, and there really wasn't much about. There was little CPD, there was no textbooks, there just seemed to be a background something or other. Now there's courses about it, there's dedicated clinics. You just need to ask. So as an owner, if your dog has been diagnosed with osteoarthritis or suspect osteoarthritis or any musculoskeletal disease, and you would like more dedicated attention, ask. If you don't ask, you don't get. And if you don't ask, we're not going to see a continuing movement of change to offer more for these diseases. Number 5.
Give pain management a chance. Like, give it long enough to make that difference. If there's been pain for such a long time prior to starting on a pain medication, you're not likely to see changes within the first 2, 3, 5, 7 days. Give it enough time.
I like that. No, definitely. Number 4 is like a little tag on from that as well, is when talking about pain relief and giving it time, when you're maybe dealing with behavioral changes that are associated with pain, don't expect them to change immediately as well. Don't expect the dog's structure to change immediately. Don't expect the gait to suddenly become 100%. Don't expect them to be able to suddenly jump into the back of the car. Not they should anyway. And I think people think everything's like a light switch. Oh, give them pain relief, and that aversive behavior is going to just stop. You know, no. It's taken a long time to get here. It's not just going to stop. So, as you said, in a wider picture, give time. Number 3.
Oh, gosh.
I think small changes. Don't feel pressure that you have to do everything all in one go. Like you said, you took a long time to. I think sometimes owners can feel overwhelmed that they have to do everything in one go. They don't. It's the small changes. It's the runners. It's the rugs. It's the ramp for the car. It's the weight loss. You know, pick one at a time if you're feeling overwhelmed. Because I also think, you know, owners have the potential to come into a consult room. They get bombarded with information. And then they walk out going, I don't even know. I don't even know where to start. And maybe the guilt as well has also started to kick in a little bit.
Yeah.
And we're not. That's not what we're about. Especially that, you know, the veterinary team we're not trying to guilt trip. So one thing at a time. If you're feeling overwhelmed, pick the one thing you think is achievable for you, and then start from there.
Yeah, I love it. I'm just going to quickly bring up Alicia's point before we do number 2. It's really common, both in cats and dogs, for the vet to not have the ability to observe those changes that indicate underlying discomfort in that 5, 10, 15 minutes of focus in a consult room in a first opinion practice. So go prepared, Alicia. There is something on the CAM website called the suspicion of chronic pain chart. Lynn will put a link to it, and that gives you the ability as an owner to write down the things that you see, whether they're posture change, physical changes, gait changes, behavioral changes, and they all point to chronic pain. So the vet in charge of the case can see that you've got behavioral changes, you've seen coat changes, you've seen that they don't like being picked up, they aren't able to jump onto the work surface, and they're like, oh wow, yeah, that all does come together. to suggest underlying pain. And also there is a massive trend towards people becoming a lot more aware about underlying pain. So bear with, Alicia. And if you still feel that you're not getting the attention that you need, then you just say to the practice manager, the receptionist, hey, is there anybody here that's really like keen to talk further about underlying chronic pain? Because I just feel that I need to have somebody that's passionate about this. Number 2, I've lost my train of thought. Number 2, I know. I'm going to do a blatant plug.
Oh.
I think since I've been doing this, I've come to realize there's so much an owner can do, and a lot of it's free of charge. And what underlies these interventions that are free of charge, which are called the game changers, is education. And as you just recently said, it's so time pressured. There's so much stress in that consult room. So CAM has created a huge amount of resources for you. Some of them is free learning. You can just go to the website, mooch around. It's like being in a department store and you're just kind of like window shopping. Pick what you want. But if you know that you would do better with some structured learning, where you get taken on a learning journey, we have a free of charge email series. It's 10 daily emails that talk you through the main concepts. But we also have an owner course. We have 2. We have CAM Essentials and CAM Comprehensive. And the idea is it gives you all of the tools to work better with your vet and your vet nurse. So you can sit at home, have a gin and tonic, go through the course, collect your thoughts, and go in with better understanding. So please get the education. Number 1.
Multimodal.
Yeah.
I think multimodal. Don't just go with. There's a lot of things you can do. It's not just about medication. There's physio. There's laser. There's lifestyle changes. There's behaviour work you can do. Like it's a bigger with OA. It's a bigger picture to deal with. So that's, I think, for me, especially working in a clinic like this, it's you've got to throw everything at the disease, as far as in my opinion, to make the animal more comfortable and improve their welfare.
Yeah, and that doesn't need to be expensive. I think when people hear multiple, they see multiple pounds. When we talk about multimodal, quite often it really doesn't cost very much at all. And it's just about having a broader understanding of what can have effect. I'm just going to tackle this one really quickly. So, Denise, yes, dogs can become very weak on their back legs because of underlying osteoarthritis, but that is not what we call pathonomic, i.e. weak back legs doesn't definitely mean arthritis. So first of all, I would go back to your vet and just say, can we go for a full clinical exam together? I want to check neurologically, is everything okay? I want to see if I can target where the source of discomfort is coming from, so I can tailor a plan. It might be that your dog has got arthritis and your pain management plan, and then you've got a support harness so you can support their front end and their back end, and you've got your rug stand, and you're doing a building exercise plan just to try and keep a little bit of stamina and strength in those back legs. Or it might be that your vet does a neurological exam and you've got such severe what we call proprioceptive deficits that we start thinking maybe there's a neuropathy, maybe there's degenerative myelopathy, maybe there's something else going on. So I would try and get your vet to spend a bit more time with you and really do a good clinical exam. From that point, if you get the answers, I would definitely look to see a physio first, because physios tend to have an understanding of hydro, massage, laser. They're like the control center of choosing where to go with which, but make sure you find a physio that works with your vet. But in these situations, and I see this all the time, look at what you can do. You might be over exercising, you might be under exercising, your dog might be falling down the steps to the back garden on a regular basis, might be slipping on the laminate floor in the kitchen, they might still be jumping out the back of the car, they might still be doing rough and tumble with next door's dog. And actually, if you modify a lot of that, then you start getting on top of things and the pain medication can start to kick in, and then you can start rebuilding. But do go back and speak to your vet. And join Cow Member Zone, because we do teas and chats monthly where we actually answer questions like this. So come and join the Member Zone. Wonderful, guys. Is there anything that you would like to add before we say goodbye to anybody? Everybody, not anybody. Everybody. Say goodbye to anybody.
No, can't think of anything.
Thank you for having us.
Yes, absolutely. Yes.
No, thank you for actually coming and sharing your experiences and knowledge. So these two lovely ladies, just to recap, are vet nurses that work at Nupsala Veterinary Clinic, which is based in Melton Mowbray, which is really leading a change with creating a clinic that is dedicated to arthritis, be it from the moment that the owner is greeted through their first walk into the door, into the waiting room, to the actual diagnostic workup, the management plans, the reassessments. It's all focused on what can we do for the best of that dog. And I think it's really admirable. So definitely wanted to chat to these guys. I want to say a massive thank you to our sponsor, the wonderful Big Barker Bed. Thank you so much for all your support of Cam. We really, truly wouldn't be here without you. So thank you, thank you, thank you. Until next time, thank you so much for listening, guys. And thank you, Arianne and Kirsty. We'll see you again soon.
Bye.
Bye.